neoplastic. We've done this for every chapter. If you want to do that, fine. We have to remember with CNS, you have to add the fourth category to really be fair, and that's the traumatic category. So we'll be talking about hemorrhages and brain trauma as well. Now, if you want to do it that way, that's fine. The way Robbins has had it organized, however, is to do a series of questions, and I think that this all relates to the degenerative, inflammatory, neoplastic as well. We have basically 13 questions. Number one, what are the general patterns of CNS cell injury? What are the consequences of increased or decreased CNS pressure? What are the common patterns of CNS malformations? You know, these are your congenital malformations again. What are the common perinatal CNS injuries? What are the common findings? What are the patterns of CNS trauma? What are the patterns of CNS vascular diseases? And what are the patterns of CNS infections? And as you can see, these all relate basically to our 3 or 4 categories again. And that's what we'll be talking about today. We'll be answering the first 7 questions today. And then on the last pathology day of the world, which will be Thursday, we'll deal with the little more exotic type diseases like prion diseases, demyelinating, degenerative disease, some of the more interesting but common diseases. Okay, so what are we going to talk about next? I think the best thing to talk about is to actually show the big cell of which the central nervous system is all about. As you know, it's the neuron. This is a great diagram. There are several big lumpy processes that come out of neurons. There's only one axon, but everything else is a dendrite. And if you want to know the difference, sometimes it's hard to tell when you're looking in histology. Just remember, the nissl substance or the granular substance will actually go into the dendrites, but they do not go into the axons. And sometimes that's the way you know from looking at a cell, besides having the fact that you have a large nucleus and a soma or perikaryon, which is a cytoplasm around that nucleus, and then these multiple processes, whether they're axons and dendrites. If they wind up being an axon, they won't have nissl substance or RNA granules going into the mound, and it may very well be myelinated at some point in time. Another thing to remember is that probably 90% of the cells in the central nervous system, I mean, I might have that percentage wrong. It might be 80 or it might be 95. But about 90% of the cells of the central nervous system are not neurons. So the vast majority of the cells of the central nervous system are supporting cells or glial cells. And if you're in the brain, most likely they're astrocytes. And if you're in an area where there's a tract and there's myelination, it could very well be an oligodendrocyte. And if you're in the CNS ventricle or the choroid plexus, which are the papillary structures that create the CNS fluid, the CSF fluid, most likely it'll be an ependymal cell. Otherwise, the tiniest cells are probably going to be microglia. And those are going to be the things that proliferate like lymphocytes or neutrophils. And there's a lot of nonspecific brain injuries because even though you can have lymphocytes and neutrophils in a brain, remember, those cells themselves are not normally part of the CNS substance unless they enter it from a blood vessel. So the microglia are the primary inflammatory cells of the central nervous system. Here's what it looks like. I think when you are looking at various parts of the brain, you know, Dr. Dan's telling you about brain anatomy and brain physiology. And, you know, you probably can get totally lost when it comes to these various portions of the brain. But the histology is remarkably simple. Whenever we see a big cell like here or here or here or here, there's 4, 5, 6, 7, 8, 9, 10. There's about 20 cells in here, which you can tell are neurons. And there is so much cytoplasmic granules in the perikaryon or the soma of these neurons. Often it obscures the nucleus. Sometimes, like here, you can see the nucleus. Every other nucleated cell that's not one part of these big cells are glial cells of some sort. And also, I'll give you another little thing to remember. Here, I'm going to blow up this little cell over here. Another thing to remember is that all of these small cells are glial cells, and these two large cells are neurons. And if you have a good, nice section through the middle of the nucleus of a neuron, you will almost always see a prominent nucleolus. Now, here's a good rule of thumb. Generally speaking, the nucleolus of a neuron is about as big as a whole nucleus of any of these other glial cells. So keep that in mind. And remember, once again, if you see what looks like a process coming out of one of these neurons, but the nissl substance or these granules end and do not go into the process, that's probably the axon. Or if you see these granules actually start going into a process like here, that's probably a dendrite. And I will be very honest with you, in terms of the glial cells, which are 90% of the cells in this picture, very often you can't tell which is which. Very often you have to toss a coin, whether it's an oligodendrocyte, an astrocyte, or a microglia. You know it's certainly not an ependymal cell because we're not in the CSF ventricles at all. Okay, here's another nice picture. You can see some blood vessels along here. Sometimes the cells that you see in brain are actually the endothelial cells of a blood vessel. Here's a blood vessel here. Here's one coming around here. If you were lucky enough to see a red blood cell in there, you'd know it was. Otherwise, you can see that there's a few nice thin endothelial cells. These are the capillaries. Another thing to remember is that if you see a cell and it has a halo around it, you know that that has to be an oligodendrocyte, right? Why? Because we told you that the oligodendrocytes make myelin. And just like the myelin of the Schwann cells, in normal stains, myelin is fat, and fat washes out on the histo preparations. So as a result, the oligodendrocytes all look like they have halos. So you can see the majority of the cells in this picture are probably oligodendrocytes. The ones that clearly do not have a halo and maybe a smaller nucleus, those could very easily be microglia. And remember, we told you that the astrocytes are the cells of the so-called blood-brain barrier, which is a nice physiologic term, but it's also an anatomic term as well. So an astrocyte process is basically what wraps around a capillary and creates that blood-brain barrier. And it is the major cell between the neuron and the blood vessel. Okay, here we go. Here's an astrocyte, like I say, wrapping around a blood vessel. Here's an oligodendrocyte making myelin. Here's a tiny microglial cell with a lot of processes. Remember, the antigen-presenting cells, the macrophages, the histiocytes, so to speak, they have a lot of processes, so they come in surface contact with various things. And the ependymal cells are the only glial cells that look like epithelial cells because they are lining the ventricles, aren't they? And if you remember, this lining is in a papillary arrangement in the first or the lateral ventricles, which is really the first and second, as well as the fourth ventricle, because this this epithelium becomes papillary, is actually now becoming a choroid plexus. And as you know, choroid plexus has these papillary arrays of ependymal cells to create the cerebrospinal fluid. Here is a nice stain for astrocytes. This is a special stain. This is not a routine H&E. And as you can see, you now know why the word astrocyte got its name, because it has all of these spiny projections, which eventually will be in contact with blood vessels. And this, you can also see these other cells here, which have halos around them. You know that they have to be oligodendrocytes, don't you? And you also know that because you don't really see too many neurons here, but a lot of oligodendrocytes, you're probably in the area of white matter or nerve tracts rather than gray matter, or where there's a lot of neuron bodies. This may very well be a neuron body over here, or a neuron. Um, Here's another beautiful view of oligodendrocytes. Almost every cell in here is an oligodendrocyte. And once again, here's an ependymal cell. It looks like it almost has cilia, and it looks almost identical like ciliated columnar cells. If it's just flat like that, it's probably lining a ventricle somewhere. If it's forming a papillary array like we see here, these are the same cells, then this is going to be part of choroid plexus. And you know, the lateral ventricles and the fourth ventricle are very, very rich in choroid plexus because that's the major producer of the cerebrospinal fluid. The microglia are the most difficult of all cells to appreciate when you're looking at sections of brain. But the one thing you can bet on is that there's an area of brain injury and there winds up being an influx or increase in certain number of cells, you can probably bet that they're microglia. And not only are they have the histiocytic or macrophagic properties, but you can see they also have the capacity to coalesce their cytoplasm, just like other macrophages do, to form giant cells. So if you want to think of microglia as being the tiny macrophages of the central nervous system, that would be very good for you to think that way because that's exactly what they are. So let's talk about some diseases now, and let's talk about, first of all, some classic cellular reactions. And remember, this is not going to be any different from day one when we talked about general cellular reactions to injury. We're going to talk about two things that happen when there's a non-specific central nervous system injury or disease process, and one of them happens to the neurons and the other thing happens to the glia. Well, one of the things that the neurons do when they get injured is for the cytoplasm to become red, and that's probably because of degenerative protein changes inside the neuron. But remember, we said in any cell, you could eventually have breaking down of the nucleus and dissolution, the process of karyorrhexis and karyolysis. And also, you can have degeneration of the axons as well. As you would guess, if the neuron dies, the axon dies. That makes pretty much sense, doesn't it? Because it's the actual neuron and the cytoplasmic mass around the neuron, called the perikaryon, or soma, if you will. These are the things that are sending nutrients to feed that neuron. And remember, a neuron may only be like 20 or 30 microns in diameter, you know, but an axon could be 3, 4, or 5 feet, you know. Also remember, non-specifically, you can have inclusions inside the neurons. You can have lipids, proteins, carbohydrates, viruses. Just like we said on day one, you can have buildup of materials in the cell that shouldn't normally be building up. Now, if you go to the 90 or so % of the cells that support the neurons, one of the big things that happens is that there's swelling of the cells. Well, we told you that on day one. We said when a cell is injured, whether it's a glial cell or a neuron or not, it's going to take on water. It's going to lose its capability to keep sodium out. And that may be a permanent change, eventually resulting in death, or it may be a temporary change. The glia can also take on material like inclusions. Think about it. If you have some dead tissue or extraneous tissue in the brain and there's a gliosis reaction to it, the microglia are going to pick up little particles, aren't they? But the thing that is in the biggest letters here is the word gliosis. And I'm going to tell you now what gliosis is. Gliosis is nothing more than an increase in the number of glial cells. Gliosis is a totally nonspecific finding. Gliosis is as common with central nervous system injury as infiltration of neutrophils or lymphocytes or macrophages is with injury anywhere else. So gliosis itself is a non-specific injury reaction to the brain. And guess what? So is edema. Why? Think about it. You know, if you've ever seen an MRI scan, you'll see the radiologist will be showing you these little areas of increased signals. Well, what do you think those signals are coming from? They're coming from protons, aren't they? And where there are more protons than normal, you have more signals than normal. And the reason why there's more protons is because there's more water. And the reason why there's more water is because there's swelling. So, make a long story short, anything non-specific thing in the brain that results in some amount of swelling or increased water will show up as increased MRI signals, especially on T2 weighted images, when they tweak the magnetic coils in such a way that they are trying to enhance water or enhance the density of protons. Okay, you see these neurons here? You see how they're redder than normal? Do you see how they look like there's no good delineation of the nucleus, even though they're cut at various levels? Those are red neurons, and these happen to be in the cerebellum, those large Purkinje cells, you know, which are the largest neurons of the central nervous system. And here's another situation in which you have some chronic central nervous system injury. And you could see that there are generally more glial cells than there should be. So, you know what? I didn't make a separate PowerPoint for this phenomenon, but I want you to right now take down a note, maybe a piece of paper, or maybe memorize it forever. The three common phenomena in central nervous system diseases is edema, gliosis, and demyelination. And remember that these are all non-specific processes because they occur no matter what the primary disease is. Is it a stroke? Is it a tumor? Is it a degenerative disease? Is it a metastasis? Is it a gunshot? Is it a bullet track through the brain? All of these things will produce edema, gliosis, and demyelinization. Okay, well, let's talk about one of the primary things now, edema. In other words, if I told you that the normal weight of a brain was 12 to 1,300 grams, and you take one out at autopsy and it's 1,500 grams, you would say this is heavier probably because there's more water in it. That's edema. There's two kinds of cerebral edema. One of them is due to the fact that there's some kind of disruption of that delicate thing we call the blood-brain barrier, the BB, and therefore water accumulates, and this is generally between cells. But remember, we also told you on day one, as well as 5 minutes ago, that when a brain cell is injured, whether it's a neuron or whether it is a glial cell, the cell itself takes on water. So you can have a type of edema that is primarily intracellular, which is usually cytotoxic, as well as something that is vasogenic, in which you have something wrong with the general blood-brain barrier. And one of the things that might be wrong with the blood-brain barrier is that there's a tremendous dilatation of those blood vessels or injury due to acute disease. As you might guess, in other organs that are edematous, like a liver or a spleen or a kidney, they swell, they get bigger. But you know that the brain is inside of this jail called the cranium, so it can't get bigger. So I know what you're thinking. You're thinking, well, how could a brain become bigger if it is not allowed to expand? Well, one thing that it does is for the the gyri to become flatter. Another thing that it does in the parts of the brain where there is technically an area for the brain substance to ooze through a potential space, like the tentorium, the cingulate gyrus, or the cerebellar tonsils, where you have all those big cisterns, remember? That's where you see some creeping of the brain substance into these potential areas of decreased give where the brain can expand. Let me show you an example of that. Here's the most common example. If you look at 1,000,000 brains and you say, well, I know when you look at the brain, you see a nice round pattern to these gyri, which are the hills, as well as the sulci, which are the valleys. And you say, well, this is a nice little rounded pattern, you know, like a Irish landscape of rolling hills. But let's say that there's increased fluid, but the brain is not allowed to expand. It manifests itself by having a flattening of the gyri and a narrowing of the sulci. And that's because you have increased fluid in that brain, but it has nowhere to escape to, so the gyri generally become flatter. And if you remember also from your brain anatomy that you have a thing here called a falx, which is the dura mater extension that separates the cerebral hemispheres. But right at the tip of the falx, you have the cingulate gyrus. You remember that? And technically, if there was something going on in this part of the brain that resulted in edema, which means any non-specific injury, you can have a little herniation of the brain substance or of that particular gyrus underneath the falx. So that's what they call a subfalcine herniation. It's a herniation of the falx in the inferior most portion of the falx. Another technical place, if you remember, you have this big fibrous membrane called the tentorium separating the supratentorial structures of the brain from the infratentorial structures, which is basically the cerebellum and the brainstem. And technically, there could be a herniation of the brain through the tentorium as well. That's another area. And if you also remember, when you looked at the brain, there were these big cisterns right near the foramen magnum, you know, right where the medulla is coming out to become the spinal cord. And technically, there's a lot of cisterns there which act as reservoirs for cerebrospinal fluid. Well, technically, if there was a lot of edema in the cerebellum or infratentorium, or what they call posterior cranial fossa, these are all names for the same area, you can have herniation of the cerebellar tonsils through the foramen magnum. So that's one of the things you look for when you're doing an autopsy of somebody that died. You look for little notches or herniations of the cerebellar tonsils, or the cingulate gyrus, which is the part of the brain here that could potentially herniate through the tentorium, or even subfalcine. And if you would guess, if this was a diffuse brain edema, you would probably not have one area herniating to the other side. It would probably not look like it was herniated at all because the whole brain in general was edematous. So these are the three areas where you would expect to look if there was some cerebral edema. And here's some examples. You could see that these are areas that are not only edematous, but they look like they're a little bit hemorrhagic too. And as a result, they're going to show some, besides the hemorrhage, I told you that edema is also going to be present. So they're going to show some herniation or prominence of this tissue trying to go through those three potential holes. Look at the cingulate gyrus here. Remember, that's part of the hippocampus. Does this all is it all coming back now? If you look where this little pin is put, there is a very prominent notch on that cingulate gyrus. And that means that the brain was edematous, and of course, it couldn't expand through into the into the posterior fossa. So it became notched because the cingulate gyrus was being pressed against a bony structure. Here's a cerebellar tonsil. Look, do you see how the inferior portions of the cerebellum look like they have a nice little notch on them? And the little yellow area shows where the notch would be. These are actually cerebellar tonsils that want to go through the foramen magnum with the spinal cord, simply because there's a lot of edema in that posterior fossa. So that's a cerebellar tonsillar herniation. Okay, we talked about findings and concepts and everything. Let's talk about some of the symptoms of cerebral edema. As you might guess, any significant traumatic or infectious or any disease process at all, which is diffuse with the brain, could potentially and usually cause cerebral edema. So what's the differential diagnosis? Everything, because remember, we said edema was a nonspecific process. The symptoms are also non-focalizing as well because it's a diffuse process. But if you wanted to quantitate the symptoms from the mildest form of edema to the most severe form, which is death, you might want to remember that headache would actually come before hallucinations, and hallucinations would probably come before coma, and coma generally comes before death. Okay, it's 9:41. I think we've covered a lot of the basics. I don't want to take a break yet, but I do want to go into another really, really interesting topic. But before I do, I'm going to have to force everybody with the question again. Can you hear me? Because I've been seeing a lot of quietness out there, and I know I'm still on the line. So I'm assuming I'm going to be hearing a bunch of yes, yes, yeses pretty soon.
Oh, yes.
Okay, I'm seeing a bunch of yeses. Thank you. So let's continue into the concept of hydrocephalus now, and then we'll take our break. Hydrocephalus is one of the most confusing topics because everybody has a great misunderstanding of what it means. But I'm going to tell you the definition of hydrocephalus, and it's not going to be what you thought it meant. But before I tell you what hydrocephalus is, we have to review the anatomy and physiology and flow of CSF, cerebral spinal fluid. Do you remember these two gigantic C-shaped structures called the lateral ventricles? Do you remember we just showed you a picture of choroid plexus inside these lateral ventricles? Well, that's where CSF is made. And it's made in the left lateral ventricle, and it's made in the right lateral ventricle. And you probably know that it's always called the left and the right ventricle. It's not called one or two. If you were to say, what is the first ventricle the left and the second, and nobody knows that because nobody ever calls them 1 and 2. They do, however, call something 3 and 4. If you remember, the third ventricle also has a little bit of choroid plexus to manufacture cerebral spinal fluid. And there's a good amount in the fourth ventricle now, which is at the base of the cerebellum and the brainstem. So this is where the CSF is made. And the CSF, as you know, lines the entire ventricles and the aqueducts that connect the ventricles, and even all the way down into the middle of the spinal cord. So remember, that's where the CSF is made. Once the CSF gets down to these big cisterns at the base of the brain near the foramen magnum, it then starts to circulate through the subarachnoid space over the convexities of the brain, over the hemispheres, and as well as the subarachnoid space of the spinal cord. And eventually it gets absorbed through the arachnoid granulations, also called the Pacchionian bodies, if you want to remember that. If you don't, just remember it all gets absorbed in the right near the midline of the brain. You see Pacchionian granulations, or what they call arachnoid granulations. You could even see some indentations of them on the calvarium. They're very big. But it's made in the ventricles, and it gets absorbed parasagittally on both hemispheres. Okay, now I can tell you the definition of the word hydrocephalus. The definition of the word hydrocephalus is anything that interferes with this normal pattern of production, flow, and reabsorption. That's the definition of the word hydrocephalus. Most of us think of hydrocephalus as kids with big brains. And of course, that's true also. But in that type of hydrocephalus, the skull bones have not fused, and therefore the brain expands due to this tremendous dilatation of the ventricles. And that's what we normally think of as hydrocephalus, but that's just a small part. Hydrocephalus is any pathologic condition which interferes with normal CSF production, flow, and reabsorption. And probably if you had a process that was resulted in impaired reabsorption, that would be hydrocephalus. If it resulted in increased or decreased production, that would be technically hydrocephalus too, wouldn't it? If there was a normal production, but there was some type of obstruction along the path, perhaps maybe a tumor in the one of the aqueducts, that would be hydrocephalus too, wouldn't it? If the problem involves the entire CSF compartment, that's a communicating hydrocephalus, isn't it? If the increased pressure or obstruction or problem was only in a part of the CSF compartment because there was an obstruction, that would be a non-communicating, wouldn't it? If the CSF was either being overproduced or decreased reabsorption, that would be high pressure, wouldn't it? Or if there's some problem with the overall flow, but the CSF pressure is normal, in other words, you go to do the spinal tap and it's a normal pressure, then that's a normal pressure hydrocephalus. And these are all adjectives that are used to describe different types of hydrocephalus. And by the way, I want to change what looks like a typo here, because like I said, anything is possible, but in most hydrocephalus, you're going to have impaired production or, no, this is probably pretty good. This is accurate. So that's what we normally think of as a hydrocephalus. It's a kid with a big head, and the reason why the head is big is because the ventricles and perhaps the entire CSF space is large, and the skull bones have not fused yet, so therefore the head is big. And if you want to look at what some of the hydrocephalus might look like on CT, you just see big ventricles. And don't forget, you can have big ventricles purely on the basis of cerebral atrophy, like in an Alzheimer's disease. But if you've looked at a lot of CTs or MRIs, and you can see that the ventricles look like they're about half the whole cross-sectional area of the brain, these are enlarged ventricles. For the most part, you can probably say there's some kind of hydrocephalus going on here. Look, in an area like this, you might have really enlarged and bulging lateral and third ventricles, but the fourth ventricle, which you can see down here, is normal. You would think, well, maybe there's an obstruction in the aqueduct connecting the third to the fourth ventricle, the so-called cerebral aqueduct. And if it was stenotic because of a congenital problem or a tumor or something externally pressing on it, you would expect to have very, very large lateral and third ventricles, but a normal sized fourth ventricle. And here, let me point this out. Here's the left lateral ventricle. Here's part of the right one. Here's the entire third ventricle. Here is the cerebral aqueduct, and you can see here's a normal sized fourth ventricle here. But you can see that CSF is just not getting through. This is a classical example of a partial or a non-communicating hydrocephalus. If it was diffusely enlarged, you might want to call that a communicating hydrocephalus, in which the entire CSF compartment is enlarged. Here's another example of a hydrocephalus on an MRI, on a MRI. And let's see, I said CT, but that's wrong. I should have picked that up. This is definitely an MRI scan because you can see water as being very bright. And as you could see, when you do a T2 weighted image on an MRI, everything that's water, everything that has increased protons, everything that has increased protons to create signals, that shows up as very, very, very white. If this was a CT scan, water would be a lot less dense than the surrounding tissue. And look, not only do we have a lot of water or enlargement of the ventricles, but you can also see that there is some edema in the cerebral tissue that is in close proximity to the posterior part of that ventricle as well. Okay, another picture of a brain. You can see that the ventricles are divided, and I think you could really say that these are a lot bigger than they should be. And if you've cut a lot of brains, whether it's with a CT scanner or a knife like I have, or an MRI scan like I have, you can see that these are just a lot bigger than they should be. So if you want to equate almost all cases of dilated ventricles with hydrocephalus, you can, even if the head is normal sized. Okay, it's about 9:51. Let's take a break, and I feel pretty confident we could probably finish up the second part of this after our break. There's no reason to run overtime today. I promised my gut to get another cup of coffee, so we could probably continue our discussion on part one, central nervous system, after we have generally defined the normal anatomy, physiology, general patterns of disease, and the CSF flow abnormalities as well. So I'm assuming everybody can hear me. And Ilam, I'm sorry if we couldn't hear your music. I know I couldn't hear any of your music at all. So that's why I started playing. I didn't want to play over you or anything, but I just couldn't hear anything from you at all. So if it sounds like I was working out, it's because I ran up 3 flights of stairs. And being an old man, I could get a little short of breath over not much these days. So let's talk about CNS malformations now. And because we're back here, and I hear a lot of silence, I'm just wondering if everybody is still there again. So I need another show of hands. So if I see 5 or 6 yeses in a row, we'll continue. Thank you. If you remember, the general development of the central nervous system just starts out as a tube, and the cranial part of that tube becomes the brain, and the tail of the tube becomes the spinal cord. So when you kind of remember the various types of thickenings and foldings and secondary foldings that happen, and you think of any possible thing that could go wrong in that little scenario of the tube becoming round and then closing off and then becoming thick at the front portion, that's basically the classification for CNS malformations. If you don't have any development of the cephalic or cranial or superior portion of the tube, technically, that would be anencephaly, right? No brain. It's not as rare as you think. An encephalocele would be a situation in which there is development of the brain, but there's perhaps a remnant large open water-filled space. If you have failure of closing of the neural tube, especially in the spine, dorsally or posteriorly, that would be the basis of spina bifida, and that would include not only perhaps the neural portion of the tube, but the overlying, bone and soft tissues as well. You can have specific forebrain anomalies, which we'll talk about, like polymicrogyria, in other words, small gyri. Holoprosencephaly, which is a failure of fusion of the forebrain, might result in a baby having only one eye or cyclops, Many of the holoprosencephalies become psych plaques or agenesis of the corpus callosum. And this is not that uncommon either. And it's also not necessarily associated with disease, central nervous system diseases at all. There could be people walking around that don't have a variety of infratentorial lesions, like the Arnold malformation, in which you have a severe infratentorial herniation. Remember, we talked about tentorial herniation with edema. Well, there is a malformation type in which you have a large one. And also you can have what they call a dandy walker, which is a large dilatation of the cerebellum. The dandy walker is a cerebellar cyst involving a very, very large fluid-filled space in the middle of the cerebellum of the fourth ventricle. You can also have what they call a syrinx, in which you have an increased amount of fluid and space in the middle of the spinal cord. And we'll give you an example of that as well. Well, here's an anencephaly. And even though it looks like there's a head, there may not be much of a brain. And actually, these are not that uncommon, but they have a very distinctive appearance, and this is simply a failure of development of most of the brain tissue. Here is the inferior and posterior part of the tube that never closed. So this could result in a spina bifida, or a bifid spine, in which, if you remember, the posterior part of the tube fuses. Well, in this case, it didn't fuse, due to a variety of reasons. Here's polymicrogyria. And if you look at this brain, you could really say, hey, you know, those gyri look a little smaller than usual. And that's exactly what it is. It's a situation in which the gyri don't fully develop and they look smaller. So they have an appropriate name. Here's a holoprosencephaly. This is limited to the forebrain, or prosencephalon, which is the same as the forebrain, in which you have a failure of separation of some of the frontal lobe structures. And as a result, the baby may have only one eye. Believe it or not, this is not that rare. Another thing is that, thank God, most of these things that we have shown you so far have been incompatible with life. And they're just found at interesting findings for stillborns. Here's a situation in which, if you know, you have a nice stain here which separates gray matter from white matter. In this case, the white matter is yellow and the gray matter is pink. But there's always a nice big band of fibers, myelinated fibers, called the corpus callosum. And as you know, they are basically the main connector of the two hemispheres. Well, in some people, like here, you don't have a corpus callosum. You have an exaggerated cleft between the two hemispheres, and there is no white matter bundle connecting the two. This is an absent corpus callosum. I don't know a hell of a lot about this disease, but I do know a lot of times it's picked up in adults and kids that either had mild symptoms or never even knew they didn't have a corpus callosum. It's possible one of you don't have a corpus callosum and you'll still get a high grade on your USMLE Part 1. Here's a syrinx, which is the radiologist term or the short term for syringomyelia. And the reason why it's called, I don't know why it's called syringo, but you could see here is the spinal cord passing through the foramen magnum. And you can also see that the normal central canal, you remember that little tiny central canal of the spinal cord, is very, very large and is filled with water. And it has the appropriate name, syringomyelia. Okay, let's talk about general perinatal brain injuries. And now we're not talking anymore about embryologic errors of development of the neural tube. We're talking about actual brain injury, usually very often associated with very difficult delivery or extreme premature things. The general name for a significant and usually non-progressive diffuse cerebral pathology apparent as birth is called cerebral palsy. And it's a wastebasket term. it could really be anything causing it, including difficult obstetrical delivery. Of course, the malpractice lawyers would like to make you believe all cerebral palsy is due to malpractice. And the general rule that all the OB doctors know is if you have delivered a baby with cerebral palsy, even if the delivery went perfect, somebody is going to lose a lot of money to support that baby for the rest of his life. One of the most common non-specific findings in a perinatal brain injury is not only general hemorrhage in the brain, but for some reason, especially in premature babies, intraventricular hemorrhage. It's very, very common. So you do an autopsy on a stillborn baby or a baby that died perinatally, no matter what the cause was, you're very, very likely to see hemorrhage inside of the ventricles. And associated with hemorrhage inside of the ventricles, you can see little infarcts and softening of the periventricular tissue. And rather than just throw these words at you, let's take a look at it now. Here is a baby that has a lot of blood inside the ventricles. And here, there may not be a lot of blood, but there is a lot of dead brain tissue or ischemic tissue in the periventricular portions of the brain. You could see that if a brain has blood in it and it's still liquid, it may show up as a nice line here. Whereas if a brain has actually started to form a clot, you won't have a gravitational line when you do the CAT scan or the MRI. Here's another MRI of a brain now in a baby, and you may not see a heck of a lot of fluid in the ventricles, but you can see a lot of edema and therefore some kind of damage in the periventricular basal ganglia as well. Okay, let's talk about the general patterns of CNS trauma. Let's talk about skull fractures. Let's talk about parenchymal injuries to the brain, traumatic injuries. Let's talk about injuries due to trauma of the blood vessels. Let's talk about clinical sequelae. And let's talk about spinal cord trauma as well. Let's define the words at first. A contusion of the brain, like a contusion of anywhere else, is a bruise to the brain. A laceration to the brain is a tearing of the brain. Remember, it's not a surgical incision, it's a tear. Sometimes you have the concept of coup contra coup. In other words, let's say that the frontal part of your brain, your cranium, your skull gets traumatized, but it's actually the occipital portion that winds up having the injury or the subdural or the hemorrhage or whatever. And you could imagine in a contra coup injury, even though one portion of the head is being traumatized, it's the opposite portion gravitationally that's showing the damage. And the explanation for that would be like if you just threw a football at a wall. When you throw the football at a wall, the part of the football that separates from the cranium might be the part that's not hitting the wall because you have a gravitational pulling of the brain along the side that has not been in contact with the blunt force and tearing of blood vessels. And of course, the definition of a concussion is a situation in which you have perhaps a temporary loss in consciousness or perhaps some mild, generalized, transient CNS symptoms, but they go away and you do your CAT scan and you do your MRI and you do whatever you want to do and you see no evidence whatsoever for brain trauma. So if a concussion has MRI or CT findings, it would no longer be a concussion. It might be called a contusion then, wouldn't it? In all honesty, if you were shown a picture like this on your boards, you don't have to go crazy and you don't have to say, oh my God, what exotic disease it is. I would remind you just to be very, very, very logical. All you could say here is that there are hemorrhages in this portion of the brain. It's probably near the hippocampus. And remember, hemorrhage is as non-specific to the brain as edema, gliosis, or demyelinization. It could be due to anything. In this case, it happened to be due to trauma or a contusion. Here's a case in which you have a hairline skull fracture. Can you see the little tiny hairline fracture in the frontal bone? And here's another case in which you have a lot of edema in the soft tissues outside the skull, but you can see not only a fracture in the skull, but you could see a depression of both of the tables of the skull, both the outer table as well as the inner table. This is a depressed, also called displaced skull fracture. And remember, can you see this little line here? You remember we have the so-called inner table and outer table, and the softer marrow tissue between the two areas is called diploia with that funny little symbol above the O. Well, you can have a depression perhaps just of the outer table, in which you have a thinning or perhaps an absence of the diplo. But in this case, you have both entire inner tables and outer table depressed into the brain itself. And as long as we're talking about brain skull injuries and brain hemorrhages and stuff, let's try to get something clear. And once again, I hope it's logical. There are various types of hemorrhages you can have with respect to the brain. And they have a wide variety of adjectives. And they are generally associated with certain things. For example, if you have a hemorrhage that is above or superior to the dura, it's called an epidural hemorrhage. If it's actually forming sort of a mass on CT or MRI, you call that an epidural hematoma. Because the area superior to the dura is the skull itself, epidural hematomas are usually associated with skull fractures. And so when you see an epidural hematoma on a CT, the radiologist is looking very, very closely for a skull fracture. And usually there's been a history of trauma. Okay, now let's talk about a subdural hemorrhage or a subdural hematoma. And that's a collection of blood, usually venous blood. The epidural is usually arterial because you're rupturing arterial vessels in that region. A subdural hemorrhage is usually venous blood. And this is also, as you know, the subdurals are also due to trauma. But in this case, there's no skull fracture, usually. And also, the collection of blood appears very slowly clinically. A classical picture of a person with a subdural is somebody that has a brain injury. He may not lose consciousness. It may be a kid that fell off a bicycle, and then he just feels a little tired later on when he goes home, and he goes to sleep, and he never wakes up. So in the epidural, you have a collection of blood underneath the dura, or deep to the dura. It's also associated with trauma, but there's usually no fracture, and it's venous blood. Now, let's talk about subarachnoid hemorrhages. So most subarachnoid hemorrhages are not associated with trauma. If you remember, the subarachnoid space, whether you are in the brain or spinal cord, is the area where all of the large arteries are present. So if you have an aneurysm that ruptures, or if you have a hemorrhagic CVA, in which you have a rupture of a large cerebral blood vessel, this will result in subarachnoid hemorrhage. And the hemorrhage will dissect according to the space that it's allowed to dissect in. It may even compress the brain, but it'll basically stay limited in the subarachnoid space. If you have an intraparenchymal hemorrhage now, or a hemorrhage that's primarily in the parenchyma of the brain, that could be due to just about anything. It could be infectious, it could be traumatic, it could be ischemous. But remember, an intraparenchymal hemorrhage is usually a very, very non-specific finding. We talked about intraventricular hemorrhage, and we talked about that as being very, very common and non-specific, especially with newborn and preemies. And that is usually not associated with a trauma either. In fact, a primary intraventricular hemorrhage in adults is very, very rare. So here we are in our little anatomical model here. This nice big red line is your dura. You can see the dura is nicely connected to the calvarium here. In fact, if you remember, one of the layers of the dura is the actual periosteum of the bone, if you kind of remember that. And if you have a collection of blood then between the dura and the pia, that's a subdural hematoma. That's traumatic, it's venous blood, and it's usually not associated with a skull fracture. And remember, it can also be contra-coup. Here is the dural membrane in which the blood collection is epi or superior to the dura. Here you can see that there's also a skull fracture in association with it. And from a CT scan, it may look very, very similar unless you could actually delineate the boundaries of that dura over there, which you can usually do. So here is the outer table of a skull. Here's an inner table. You can see that there's some disruption of this inner table, and there's some hemorrhage in the diploia. But part of this disruption is that you see a collection of the blood that separates the dura. Here's the fibrous dural membrane here. So this is epidural hematoma associated with a skull fracture, arterial blood. And by the way, epidural hematomas, because they're associated with skull fractures and arterial blood and compression of the brain, you know, like the subdurals, they're very, very, very serious. They have a very high mortality rate. Here's a subdural hematoma. And if you bear with me, you can see here's the fat of the skull. But you can also see that the dural membrane, okay, which you could see right here, here's the dura. And if you were a good radiologist, you can see the dura is basically along here as well. Well, the primary collection of blood signals here now is subdural, okay, and that's your classical subdural. And you can see that this subdural can cause a very significant compression of the brain as well. Here's a subarachnoid hemorrhage. And if you remember the circle of Willis and all of the main branches of the circle of Willis, or if you would prefer to call it the anatomical circle, you can, because that's a preferred name these days, but everybody still calls it the circle of Willis. By the way, I'm very curious. When you learned the name for this structure, this arterial structure at the base of the brain, did they call it the circle of Willis, or did they call it the anatomical circle? So give me a W or an A. We got mostly W's. That's good. I hate this new trend where they're taking people and taking their great discoveries away from them because of the politically correct pinheads that seem to be running this world. But anyway, here's a subarachnoid hemorrhage. You can see there's a dissection of hemorrhage in the subarachnoid space. And that usually means one of the major arterial branches of the circle of Willis has had a disruption in its wall, perhaps a rupture of an aneurysm, maybe a congenital Berry aneurysm, or maybe an atherosclerotic aneurysm, or perhaps even a hypertensive hemorrhage combined with an arterial defect in which you have bursting of the wall and dissection of hemorrhage all throughout this subarachnoid space. Here's an intraparenchymal hemorrhage. Could that be due to trauma? Yes, it can. And as you can see, not only is the brain substance hemorrhagic, but in the areas around it, it's a little bit more spotty. In the center, it's more confluent and red, whereas towards the edge, it's just a little more pinpoint hemorrhages. That's an intraparenchymal hemorrhage. And remember, I'm not talking about a specific disease. All I'm saying, this was an intraparenchymal hemorrhage. If you got a picture of this on your boards, don't freak out. Just call it like it is. This is hemorrhage, and it's in the substance or the parenchyma of the brain involving both white matter as well as gray matter. We just call it intraparenchymal hemorrhage, and that's the correct answer. You know, here's another extensive intraparenchymal hemorrhage as well. But in addition, you can see that this is so massive, it looks like it may be involving the ventricles as well. So what does that point out? What that points out is that any significant hemorrhage in one of these four compartments we talked about can dissect or involve a neighboring compartment. Could a subarachnoid hemorrhage become intraparenchymal? Of course it can, if it's big enough. Could an intraparenchymal hemorrhage also bleed into the ventricles like you see here? Of course it is, if it's big enough. And here's a CT scan now. You know this is a CT because you can see the big bone. And this is the point I wanted to make. You can see a large substance here that's denser than the surrounding brain, and this is an intraparenchymal hemorrhage. Now, here's the question. This would be a good logical question. Do you see the parts of the hemorrhage here that have a gravitational line, like here and here? And then you see something that's similar, that doesn't look like it's liquid, it looks like it's perhaps a clot. I think you could make a logical deduction that there's a large blood clot here, and this part of it is solid, but this part of it is liquid because you have a fluid level there, don't you? And if that person was lying in the opposite direction, you'd probably see the blood on this side of the ventricle. Okay, let's talk about some general sequelae. You know, I think if you kind of take the point of view that extensive hemorrhage to the brain or trauma can develop in a wide variety of syndromes. One of them is hydrocephalus. And if you have a hard time understanding why extensive brain hemorrhage can result in hydrocephalus, let's explain it this way. Do you remember we told you that the CSF fluid is absorbed by the pachyonian or the arachnoid granulations? Well, let's say there's been a lot of hemorrhage in that area and the granulations aren't working anymore. Therefore, you will have the decreased ability to reabsorb cerebral spinal fluid and therefore have a hydrocephalus. If you remember, a lot of these fighters, you know, that have been, you know, have their brains punched all their lives, you know, like Rocky Balboa, you remember the way he talks, like, hey, Adrian, that's punch drunk syndrome. And that's type of dementia is secondary to repeated extended CNS trauma as well. And don't forget also, if you have multiple injuries to the brain, remember, one of the things in the brain are your actual axons. So with enough injury and a mechanism that is not really clearly understood, you could actually have injury to the axons as well. And remember, we talked about red axons and all that stuff. All of the non-specific findings of injured or even dead axons could be seen with chronic CNS trauma. Oh, you know what? I wish one of you can control my pointer right now, because I'm showing you a picture of the brain and you don't know what I'm showing you, and it's not a quiz. And you're basically looking at pretty good delineation here between gray and white matter. But you can see an area here where the delineation is not really that good. And you can see an area here where it looks like the gray matter is a little more hemorrhagic than it should be. Some of the changes can be very, very subtle. And even sometimes when you cut them with a knife at autopsy, you have to look very, very good. And I want to tell you something else. A lot of times when you cut a brain at autopsy with a knife and it looks normal, and you think, well, you know, maybe I'm still missing something. The advice they give you is to put on a blindfold and just put your finger on the brain substance. And even if it looks normal, if parts of the brain feel a little soggier than normal, then you know it's edematous, or perhaps subtle hemorrhages or changes that you can't see with your eye. So sometimes your fingers can diagnose brain edema and softening and hemorrhage better than your eyeballs can. And that's why I put that picture in there. Okay, now we don't want to neglect the spinal cord. We talked about all kinds of brain injuries. So let's talk about spinal cord trauma. When we talked about the actual patterns on the histologic level, it pretty much parallels what we see in the brain. So you could have trauma, you could have tumor, you could have inflammation, you could have hemorrhage, you could have edema, all that good stuff. You got subarachnoid hemorrhage. But as you know, the spinal cord trauma is basically a sequence of changes starting out with very mild distal changes, progressing all the way to death, depending upon what level of the spinal cord is involved. And I'm not going to go into this in great detail, but as you could theorize, when you are at the very tip of your spinal cord in those last few sacral nerves, if there was a spinal cord injury at the level of the spinal cord that the sacral nerves are coming out of, perhaps the only thing you would be dealing with was some problem with sexual function. As you go higher, in the lumbar area, you're talking about your leg muscles. You go into the lower thoracic, you're talking about your abdominal muscles. You go into the upper thoracic, you're talking about your chest muscles. And you might remember the phrase C5, still alive, because the general rule that they give is that if you have a significant spinal cord disease, a transaction below the C5 level, you'll probably live. But it's above the C5 level, you probably won't. So that's why they get the phrase C5, still alive. You might want to keep this just, I don't want to tell you exactly all the different levels of what's going to happen, but as you could guess, you basically are going from problems with sex, bowel and bladder problems, legs, abdominal muscles, chest, arms. But once you're up in that upper cervical region and you have a significant blockage or disease process involving the whole level, and it's above C5, it's usually incompatible with life. So let's talk about strokes. There's two kinds of strokes. There's strokes resulting from ischemia, or not enough blood and oxygen and nutrients. And there's a hemorrhagic stroke. It's one in which there has been hemorrhage, usually of an artery or an aneurysm, involving the same type of artery. So in a ischemic stroke, you can have, if it was global, as you might guess, that's not compatible with life. If you can have a regional CVA, which most of them are, at least for the people that live, and they result in a variety of central nervous system and neurologic and visual and speech, and basically how it works with the desiccation of the tracts. So a lesion on one side is going to involve in a motor problem on the other side. I don't think I have to go into that, but from the pathology point of view, in the acute phases of an ischemic CVA, or cerebral vascular accident, or stroke, all the same term. We said edema is one of the first and nonspecific findings. Then you could get some changes in the neurons and microvascularization, red neurons, karyorrhexis, karyolysis. And then you could have infiltration of cells to eat up all of this dead garbage, and usually it's neutrophils. That's the acute histologic changes in an ischemic CVA. Edema, death, neutrophilic infiltrates. If this tissue then goes on to have a chronic type of CVA, most of the cells then involved would not be neutrophils, but they would be the macrophages of the central nervous system, which are the glial cells, the microglia. So this makes sense, doesn't it? We told you that neutrophils are the main cells with acute changes, and macrophages and lymphocytes are the main cells for chronic. Well, this really does not, also shows the same pattern in the brain, doesn't it? And don't forget, even though the majority of CVAs are ischemic, and I'm guessing probably 80% is a ballpark figure, it's way more than half, you can also have a hemorrhagic CVA, or death of cells, showing these same changes due to the fact that the artery that's supplying them has been ruptured. And as you would guess, the blood is going to collect probably in that subarachnoid space, isn't it? And if you remember the distributions of the arteries, and I'm sure you do, you know that most of the lateral portion of the cerebrum is middle. You know that the anterior goes all the way to supply the frontal lobe, but it goes as far back as the occipital lobe parasagittally. And you know that the posterior cerebral artery basically has a distribution all the way throughout most of the occipital lobe in the inferior portions of the temporal lobe up into its most anterior portion. So if you kind of remember that, another way to remember it is that the middle cerebral is supplying the external parts of the brain, and these anterior and posterior are going parasagittally as well. Here's a thrombotic middle cerebral artery CVA. So as you would guess, most of the damage looks like it's on the outside of the brain. You can see things like edema and hemorrhage and stuff like that, as opposed to a hemorrhagic anterior cerebral artery. So you can see the predominant pattern here is hemorrhage in that subarachnoid region, and because most of the damage looks parasagittal, even if it was as far posterior as the occipital lobe, it would still be in the region of distribution of the anterior cerebral artery. And this is going back to your basic anatomy. So these are classical appearances of strokes, hemorrhage, edema. This is the microscopic appearance. And remember, we said the earliest finding is edema. That's pretty much close to what we talked about, necrosis and inflammation in other parts of the body as well. We then say that the neurons, like you see here in B, they can degenerate and become redder than normal. You can then have some infiltration of polys or neutrophils. And of course, then in the older stages of the stroke, we're talking now weeks or months or even years later, the primary cell of infiltration are these macrophages of the central nervous system called microglial cells. And remember what else we said? Gliosis is a part of it as well, because gliosis is nonspecific and is found with everything. So if you were to ask me, well, could there be some demyelinization as well somewhere along the line here? Of course there could be. Remember, because we said that demyelinization was also a totally nonspecific process in any type of brain injury, whether it's a stroke or anything else. Now let's talk about another type of CVA, generally called the hypertensive CVAs. And as you would guess, in a hypertensive CVA, which is caused by too much pressure in the arteries, the primary process would be more likely to be hemorrhage rather than edema, because you're actually rupturing small arteries due to increased pressure inside the brain. Now, here is the question, which you may or may not know. Let's say theoretically we took a dog or a human being and we just increased the pressure inside of his arteries. We made him extremely hypertensive to the point where we know one of his brain arteries is going to bust. Well, what do you think is the area of the brain in which your arteries have the least amount of resistance to increased pressure? The answer to that question is the lenticulostriate arteries, which supply your basal ganglia. And if you remember, the lenticulostriate arteries are branches of the middle cerebral artery, and they come through the internal capsule, and they supply the caudate, putamen, globus pallidus. And theoretically, most of the hypertensive CVAs are in this region. And as you would guess, because it's due to increased blood, you're going to have hemorrhage as a finding. So the point is, if you're doing a autopsy and you cut the brain, or you're doing a scan and you're cutting it with a magnet or a CT scanner, and you could see a lot of properties of hemorrhage in the area of the basal ganglia, then you could probably suspect that this was a hypertensive CVA. You remember our little friend, the internal capsule here, which separates the globus pallidus from the putamen? Well, that's where the arteries are. And as you can see over here again, the lenticulostriate arteries, which are these little branches of the middle cerebral artery, are the first ones to rupture, usually with extreme pressure. Sometimes the word lacunar infarct is used because it refers to tiny little lakes or pinpoint areas, And often you see lacunar infarcts in the area of the lenticulostriate areas as well, which is pretty much the basal ganglia. So if you are reading a radiologist report or a pathologist report and they're talking about lacunar infarcts, you know, my dad had a couple of those. They're usually very small. They're often not even very symptomatic. They're very tiny and pinpoint, and they're usually in the area of the basal ganglia. And they're usually associated with hypertension as well. If a lacunar infarct is not a tiny little round, precise little area of hemorrhage, and it wants to become a little more bigger, like a slit, they often use the term slit hemorrhage. Here's a slit hemorrhage here. Here's a slit hemorrhage here. And it's pretty much the same process as a lacunar infarct, but now it's a little bit bigger. Let's talk about subarachnoid hemorrhage. We've already defined it as hemorrhage in the subarachnoid space. And because the big artery in the subarachnoid space, you know that it has to be due to usually some kind of rupture of an artery. The arteries which are most likely to rupture are the ones that are weakened. If they've been weakened by atherosclerosis and they wind up having a bulge before they rupture, that's called an atherosclerotic aneurysm. Most aneurysms are atherosclerotic aneurysm, and they occur with people that have other signs of atherosclerosis. There's another type of more well-defined and even round berry-looking aneurysm, which they call berry aneurysms, which are congenital, and they're usually in women. And when these things rupture, they're usually not associated with atherosclerotic disease. Here, let's make a long story short. If you worked in a coroner's office and a 21-year-old girl that was in perfectly normal health was just walking down the street one day, going to her job, and boom, she drops dead just like that for no reason, your boss, the medical examiner, will say, go find the berry, because it's the most common cause of unexplained sudden death in young women. And here we go. Here's the circle of Willis, or if you want to call it the anatomic circle. Remember, you got your anteriors and the communicating. The point I want to make is almost all of the aneurysms or berry aneurysms are going to be originating within 1 or 2 centimeters from the circle of Willis. So look at about half of them are right there where the anteriors come off. Another one is at the first branch of the middle. Another big group is right there at the origin of the middle. So when you are looking for aneurysms of the cerebral arteries, don't start dissecting the little branches. Just look at the circle of Willis and you'll find 90% of them there. And here's what they really look like. Here's a berry aneurysm, and I think you'll agree, it looks exactly like a blueberry, okay? This one does not look like it's ruptured, but it could have been. If you would guess that some of these aneurysms would rupture, whether they're berry congenital aneurysms or acquired atherosclerotic aneurysms, which most of them are, you'd expect to see extensive subarachnoid hemorrhage at the base of the brain, and that's exactly what you're seeing here. And these are things that can be clipped as well. You know, the neurosurgeons can actually save people's lives by going in there and clipping the source of the bleeding, assuming they have some good radiologic or arteriographic studies to show where the bleeding is coming from. What are the clinical symptoms of hypertensive encephalopathy? Well, remember, we told you that because they're in the basal ganglia, you expect some basal ganglia symptoms, perhaps in coordination, gait disturbances. You can expect a type of senility or dementia called multi-infarct dementia, if this was due to multiple infarcts due to hypertensive bleeds. And believe it or not, multi-infarct dementia is the second most common cause of senility after Alzheimer's disease. But in general, a person with a hypertensive encephalopathy, let's say they have a bunch of lacunar infarcts or slit hemorrhages, they generally are going to have very, very non-specific findings like headaches, confusion, anxiety, convulsions, you know, in that general order of increasing severity. Okay, folks, we still got some good time here, and we have a good amount of material on CNS infections, and I'm kind of like on a roll. I would like to finish the discussion on infections, and then I'll feel better. So let's talk about central nervous system infections. And let's say a few words. As you would guess, there's a variety of pathogens. There's viruses, there's bacteria. You could have the primary source of infection being in the meninges. You could have the primary source of infection being in the brain. Now, here's the general rule. Most of the meningitis are bacterial, and most of the encephalitis are viral. Another thing to remember is that if you have a significant meningitis and it extends into the brain, that's going to be called a meningoencephalitis. And if you have a significant encephalitis in the brain substance itself, without primarily involving the meninges, but it's big enough to extend into the meninges, then that's also called a meningoencephalitis. They could be caused by viruses, they could be caused by fungi, they could be caused by bacteria. But remember, the general rule is meningitis is bacterial, encephalitis is viral. What are the more common bacteria that cause meningitis? Well, in neonates, believe it or not, it's E. coli and streptococcus. However, in children, up until age 2 approximately, almost all of their meningitis is Haemophilus influenzae. Neisseria is the greatest cause of meningitis for adults, and it's the only one that's also contagious. So that's why when it's been certified, there's been a Neisseria meningitis, everybody goes crazy, and the kids are kept home from school, and they're giving vaccinations all over the place. The elderly people, their bacteria, remember these are all bacterial, is usually either a strep pneumonia, which is, from their pneumonia, or a listeria. These are the two common ones. And of course, if you do a CSF in somebody that has a meningitis, they're going to have neutrophils, possibly increased neutrophils in the CSF. Why? Because that's where the inflammation is. That's where the acute infection is. They're going to have increased protein. Why? Well, because of these inflammatory processes, you're getting increased release of various protein substances in the CSF. And if you want to think of those bacteria as having an increased need for glucose, which bacteria do, by the way, another finding in the lab is that there's a reduced glucose with meningitis. Now, the encephalitides, or the encephalitis are generally viral. And they're generally arthropod-borne, the most common type, so-called arboviruses. Herpes simplex is very, very common. CMV, or cytomegalovirus, also in the herpes family, also very common. Varicella zoster, also in the herpes family, very, very common. So if you were to want to lump these together, you could say the arboviruses are the most common, and the herpes family viruses are the second most common. And then if you want to go into an exotic things like the polio virus, which we normally don't see anymore, or the rabies virus, which you can see, but you probably never see a case of it, and HIV as well. You can never rule out HIV in just about anything. But the beautiful thing about encephalitis is, no matter what virus is causing it, it all has the same histologic picture. And it's usually a collection of mononucleated cells, usually lymphocytes and macrophages, in the little areas surrounding the blood vessels of the brain, the so-called Virchow-Robin space. Nobody have ever heard of the Virchow-Robin space unless you're talking about encephalitis. And then when you see a cuffing of the blood vessels by a bunch of lymphocytes and other mononucleated cells like macrophages, then they talk about the Virchow-Robin space. And remember, meningoencephalitis, either encephalitis that is spread to the meninges, or a meningitis that's spread to the parenchyma of the brain, or the encephalitis. Here's a classical meningitis. You see, there's pus in the delicate meninges of the brain. By definition, that's meningitis. Here we are on the other side of the brain, and you see this white, yellow, pussy-looking material. Well, that's pus too. Those are neutrophils, and that's a purulent type of meningitis, and this happens to be in the superior portion of the brain hemispheres. Here's a microscopic view, and you could say, whoa, look at these meninges on the right. They are just loaded, infiltrated with neutrophils. Well, you know that that is a severe, acute, probably bacterial meningitis. And look, if you also thought that there was some increased edema and even inflammatory cells in the underlying brain as well, then you could call that a meningoencephalitis, can't you? But if you just thought it was limited to the meninges, you would just call it a meningitis. Well, what can happen with these various things? Well, you can have cerebral abscesses. Think about it. Any inflammatory process involving the brain, it becomes severe enough and localized, you can have an abscess. And you can have abscesses because of a severe mastoiditis with the sinuses, the mastoid sinuses being in close proximity to the brain, or other types of sinusitis. You could have a hematogenous cerebral abscess secondary to, let's say, a tooth abstraction or other septicemia. Staph and strep are the most common organisms for a cerebral abscess. And as you might guess, like in all the abscesses we saw, you're going to have a big bag of pus, and it's more likely to be liquefied towards the center and maybe even have kind of a more thickened capsule towards the outside. If you had a subdural collection of pus, just like you'd have a subdural collection of blood, that's called a subdermal empyema. Or you can have an extradural collection of pus. For example, if there was an osteomyelitis of the calvarium, you know, one of the skull bones becomes osteomyelitic, technically you could have that abscess extending extradurally or epidurally as well, couldn't you? The radiologists love to talk about ring signs. This happens to be a CT. You know it's not an MRI because you can see the increased signals are in the bone. And you can see this big round thing here. And you can see it appears to have some kind of a fibrous capsule, but the inside is actually less density than the brain, so it could be waterish, whereas the very outside almost has like a fibrous membrane. They call this the ring sign, and it's very, very common for brain abscesses to have this ring sign. Some of the highly, highly malignant brain tumors that are outgrowing their blood supply and are liquid on the inside and firm on the outside, they can look like this as well, like the glioblastomas or even some of the metastases. Here's a brain abscess. You can see it's hollow inside because the brain pus just poured out, but there was enough reaction on the outside of this to form actually a part of a fibrous or fibrinous capsule. So this is, I would say, if you saw this on a board test, you should absolutely know this is a brain abscess for all those classical reasons. Well, it's kind of boring what to see inside of an abscess, right? Because you already know that an abscess is nothing more than a whole big bag of neutrophils. So if you zoom in on this, and you can see necrotic crud, maybe a little bit of fibrin, but mostly just a big bag of neutrophils, you know this was an abscess, whether it was in the brain or a pancreas or a thyroid or your left toenail. Here is a subdural empyema in which you could see the dural membrane right here, but it looks like there's a collection now. It doesn't look like blood, it looks like pus. And that's a collection of pus that is actually forming a compression to the brain. And it may even be forming a pseudomembrane along here, but remember, this is subdural. So here's the real dural membrane over here. Let's talk about the viral infections of the brain. And remember, we said the virals are not common to cause a meningitis, but they're almost always causing the encephalitis. We told you that the arboviruses is not a specific kind of virus, but it's any virus that is borne, B-O-R-N-E, by a arthropod, perhaps a mosquito in most cases. And if you remember, West Nile is a good example of this. The so-called equine encephalitis, there's Venezuela, and there's a whole bunch of them. These are the arboviral encephalitis. And if they're severe, they would be a meningoencephalitis. But if they're primarily limited to the brain parenchyma itself, it would be an encephalitis. We said that herpes simplex virus 1 and 2 can do it. We said that VZ can do it. We said that CMV, these are all herpes family viruses. We said that polio and rabies can do it. You know that polio was the big thing to attack the ventral horn cells, or the encephalitis portion of the ventral parts of the spinal cord. We know that rabies is a neurotropic virus as well, could be fatal. And we know that HIV can also involve the central nervous system. I'm going to go into another little viral caused disease, just so you know it's viral, called PML, progressive multifocal leukodystrophy. That's caused by the JC virus. And then there's another type of meningoencephalitis that used to be very common when measles was around, but because measles isn't around anymore, besides measles affecting the upper respiratory tract and lungs, measles was also causing a significant amount of encephalitis as well, in a syndrome or a disease called subacute sclerosing panencephalitis. You don't see much of that anymore. Now, I want you to remember this picture forever, because no matter what of the viruses are affecting the brain, you know this is brain rather than meninges, because you're right here in brain substance. If you look, you might see some dilated blood vessels. If you look closer, maybe you could think that there's a few more technical cells here in this space, this Virchow-Robin space that surrounds the blood vessels. But look, when you see a blood vessel in which there's an infiltrate of chiefly lymphocytes, maybe a couple macrophages, in this theoretical space surrounding the intraparenchymal blood vessels, this is encephalitis. And it's usually viral as well. Now, here's another neat little thing. If the encephalitis is primarily the temporal lobes, like you can see here, here's temporal lobe, here's a temporal lobe. You can see there's increased MRI signals because there's increased water. There's increased water because the brain is edematous. There's increased edema because the brain is inflamed with herpes virus. So what do you take home from this? When your patient has an encephalitis and appears to be primarily limited to either one or both temporal lobes, it's usually or almost always herpes simplex virus. Here's a nice picture of it, and you can see temporal lobes. And you can tell on this side here, which is the right side, there's a good separation between gray and white matter of the temporal lobe. It's not too involved. But on here, you can see poor delineation between gray and white matter. And look, it even extends to this portion of the lateral portion of the basal ganglia as well. This is HSV encephalitis. And if the surrounding meninges were also involved, then technically you should call it a meningoencephalitis. I think it would be not good if I didn't tell you that in rabies, which is a neurotropic virus, the virus actually attacks the neurons. And sometimes you could see these little eosinophilic inclusion bodies within the neurons. And you know this is neuron because it looks like there's a big axon process coming out, and it's 10 times bigger than all the surrounding glial cells around it. In fact, look, the nucleolus is as big as some of these other nuclei here. But just as a diagnostic thing, you may never see rabies, but you should know that when you see a intracytoplasmic big red inclusion in a neuron, that's going to be your so-called Negri body, Negri. So Negri bodies mean rabies, and they're intracytoplasmic perineuron nucleus inclusions. You should also know And, you know, I was thinking about this the other day. You always know that when you get certain uh, intranuclear inclusions like you have here, one of the first things you want to ask yourself, is this inclusion basophilic or is this inclusion eosinophilic? And I'm going to give you a really good tip now because I don't think there's any exceptions to it. When you see an intranuclear inclusion and it is very basophilic, it's probably CMV. No matter what part of the body is being infected by CMV, whether it's the kidney or the brain or the lungs, when you see a nucleus that has a prominent basophilic intranuclear inclusion, think of CMV. We said we're going to mention a couple of other cells. Sometimes in AIDS or HIV, they have described numerous times a syndrome of perivascular giant cells. You can tell these are multinucleated giant cells. So a perivascular giant cells, and usually in the white matter, is very often associated with an encephalitis due to HIV or the HIV virus, which is a little bit redundant. Remember, there's another virus called JC polyoma virus. And don't ever confuse JC polyoma virus with Jakob Creutzfeldt disease because they're two completely different things. JC polyoma virus is a virus that causes a progressive multifocal leukoencephalopathy, also known as PML. It's primarily in the area where there's oligodendrocytes or myelinated white matter of the brain. And because it primarily involves oligodendrocytes, you would guess that one of the main findings here would be a demyelination because the oligodendrocytes are making the myelin. And I'm going to show you maybe one picture of that. This is not something you should know just from looking at it, but here's an MRI. And you can see in this white matter, this periventricular white matter, there's a lot of edema. And you don't know that there's demyelination here. All you know that there's a lot of edema. And this is a typical example of PML. I want to show you another little thing that we do is if I was to show you a picture like this and told you that this was part of the brain, I think you should probably get the feeling that there are more glial cells here than you normally see in most of the white matter of the brain. I think you should also probably see that a lot of these cells here have little halos around them. So you know that not only are there increased glial cells, but you can see a lot of them are oligodendrocytes. And even if you don't have any idea of what the diagnosis is, I told you this is brain, you should understand glials. Remember that PML is the virus, the JC polyoma virus, primarily affects white matter, and it causes demyelinization. It primarily involves the oligodendrocytes. Well, look, let's say that this was a stain that stained white matter blue. Well, you can see there's a large portion of this white matter here that's not stained blue. So what do you call that? What do you mean that there's no myelin? If your blue stain stains myelin blue, and there's a big area that's not blue, then you could probably guess this is a demyelinating process. Here's a closer view microscopically, and I think you could say that here's a lot of myelin out here, but this general area in the middle has absence of blue because there's absence of myelin. So if this was a myelination stain and it is not staining, you could say it's demyelination. Okay, let's get into a couple of weird things and then we'll call it a day. Remember, we said we're not going to show you any pictures or tell you the syndrome because you'll never see a case. But remember, the measles virus was probably one of the biggest causes of encephalopathy when measles was epidemic on the planet. But now that we pretty much killed it, you no longer see the viral encephalitis due to the measles virus called SSPE, or subacute sclerosing panencephalitis. But you would probably guess, if you saw a name of a disease like this and it was called panencephalitis, it would probably be practically in all parts of the brain, hence the term panencephalitis. Let's talk about some exotic fungal critters that can cause damage. The number one systemic fungus that causes encephalitis as well as meningitis is Cryptococcus, specifically Cryptococcus neoformans. Candida is common, but things like Aspergillus and Mucor are often reported, but usually these are in patients that are very severely immunosuppressed, and so is Cryptococcus technically as well. But the point I want to make is whenever you do a spinal tap on somebody that has some kind of significant brain disease, which is just about everybody that comes in, usually do an India ink prep. Even if you're only going to see this, in 1 in 100 cases, even now, India ink preps are very often parts of normal spinal fluid exams. And the reason why this all looks black is because there's a bunch of India ink particles in there. But if you happen to have the cryptococcal organisms, which secrete a big capsule around the cell, there is a very, very loss of the ability of the India ink particles to penetrate this. So the India ink preps are spectacular because they're always these big white circles of the capsule. Some of them are buds, as you could see over here, and they have a big nucleus in the center, and they just hit you right in the face. And as you might also guess, you don't need a stain for this. You just get some India ink, mix it with your spinal fluid, look at it under the microscope. You see all these white little buggers looking at you. You can say this patient has Cryptococcus. Could a Cryptococcus form a microabscess? Sure. Any encephalitis can form a microabscess. Now, if you were to do a fungal stain on this abscess to look for yeast, which Cryptococcus mainly is, you can probably find that it'll stain very, very positively with the PAS stain or the silver stain. But even if you didn't do the stain and you looked at a big section like this, you can see an abscess here, 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 here. And if you went down on higher power, you could say it's a microabscess. Okay, are we going to say anything else? No, we'll just say one more word before we call it a day, and it's already 11 minutes, 7 minutes overtime. Just remember that malaria can form abscesses in the brain. Toxo is big, especially in HIV patients. Amoebas, you could talk about amoebic abscesses of the brain. The trypanosomes, the sleeping sickness can do it. The rickettsia, Rocky Mountain spotted fever, and the echinococcus. As a final thing, we said this before, but we'll say it again. If you have a space-occupying brain lesion in an HIV patient, it's either going to be a lymphoma or toxoplasmosis. One is a neoplasm and one is an infectious disease. But together, they comprise over 90% of the space-occupying lesions of HIV patients. We're done. I'm sorry for keeping you a little bit late, but I wanted to stay with my schedule here. And we are now done with CNS 1, and we'll finish CNS 2 on Thursday. And I'm sorry if I kept you a little bit late again, but I will give you a chance to say anything you want to say. And if you just want to say goodbye, that's okay too. Or if you just want to say, hey, I heard you, that's okay too.
That's a
wrap.
wrap.
If you want to fight with each other, or if you want to talk about who's going to share what case with who, you can do that. And Isla, thank you for hosting again. I think that Margaret's going to be very, very glad that you saved her butt twice already.